All right, well, let's go ahead and get started. So thank you all for joining today. I am Alice White. I'm with the Colorado Integrated Food Safety Center of Excellence. And welcome to the fifth and for now final webinar in our series presented by all of the Integrated Food Safety Centers of Excellence, or CoEs. So today we are fortunate enough to have Hillary Booth from Oregon presenting. So Hillary is a lead foodborne epidemiologist at the Oregon Public Health Division, where she has worked for the past 11 years. She serves as the epidemiologist for the Oregon Food Safety Center of Excellence, a team she has led since 2014. In her free time, Hillary loves to travel, especially road trips, and just returned from visiting Hell's Canyon in way eastern Oregon. So we are happy to have Hillary present today, and it looks like everything is connected, so I will turn it over to her. And just a reminder for everyone, if you have questions throughout the presentation, please put those in the chat, or at the end of the presentation, please put those in the chat box. We'll take questions at the end. All right, take it away, Hillary.
All right, can you hear me, Alice?
Yep, I can hear you.
Okay, great. Thank you so much. Good morning, everybody. Afternoon for some. Thanks for joining. I appreciate everyone coming out. Today I'm going to talk about applying model practices during outbreak response. And as mentioned, I'm with the Oregon Center of Excellence. We call ourselves the Northwest Center for Foodborne Outbreak Management, Epidemiology, and Surveillance, or FOAMI. So today the itinerary looks like talking a bit about pre-outbreak planning tools. So before you detect the outbreak, what can you do to get yourself in a good position? Also talking about tools that we have and how we use them during foodborne outbreak investigations. Also a little bit to talk about post-outbreak follow-up suggestions and some resources. And my goal today really is to put the tools and the strategies that the COEs are promoting, that CIFOR is promoting, that a lot of folks are promoting in context. Sometimes we sort of do a list of tools and all the things that are available, and my goal today is really to take some of those tools and really give you context about how we use them here in Oregon. So before I get into this too heavily, I wanted to give folks a chance to see this slide. I have some websites listed here. For example, the first bullet, some of the things I'm talking about come from the Center for Food Safety Excellence tools. I'll try to do my best to let you know when I'm talking about a COE tool. You can go to our website, coefoodsafetytools.org, or you can use Google search terms COE food tools and get there too. So that's what you've got for the rest of these. I'll be talking about the CIFOR guidelines. Hopefully you all know where to get those, but if you don't, search CIFOR guidelines. And if you spell it right, nothing else is going to come up. I'll also be talking about the toolkit related to the guidelines. I'll be talking about the EpiReady team training, and you can get to there via the NEHA website. All of the materials are there if you want to peruse. And then I'll also be talking about the SEA Rapid Response Team Best Practices Manual, which is also found online. It is a 400-page document, so you may want to check for my page number when we get to that section if you're downloading it. So take a look there, and happy Googling if you'd like to follow along. So first off, pre-investigation. What can we do, what can our teams do to prepare ourselves to be in the best position possible when we do detect an outbreak? So just as I mentioned here, CIFOR Guidelines Toolkit, these are your kind of squad goals that we're talking about here. This is where you go to find out what all of the team members need to be working on. There's a lot of information in the toolkit that helps you better understand your current capacity for outbreak response, and also you know, whether you have protocols in place for all the things that you'd like to outline, or maybe you've had experience in the past when you didn't have a protocol and now you realize it's a good time to develop one. In Oregon, we really like SOPs, standard operating protocols, and we write them up about situations that happen frequently so we can kind of standardize our response. But the toolkit, beyond the guidelines themselves, will help you identify specific CIFOR recommendations and activities that is thought to improve state and local outbreak response. So, you know, really specific information down to, you know, having specific training for specific activities, for EPI, for environmental health, for laboratory partners. And the toolkit is really designed to help you make plans to implement the CIFOR recommendations that seem the most pertinent for you to move forward with. So how does that work out? Well, believe it or not, we're doing this, we're just about to start doing this in Oregon for the first time. We have not used the CIFOR Toolkit in Oregon, but we are approaching the Select Focus Areas worksheet. And this will be how we're going to go through and assess the current state of affairs for our team. We have helped facilitate some CIFOR workshops in other states, and I don't know if anyone's on the line that's had a CIFOR workshop facilitated in your jurisdiction, but I would be very happy if anybody felt like chiming in to talk about that experience. And I should say, as I go through here, if you've had experience using any of these tools, I would really be interested in hearing from folks about sort of whether these things are implemented in your jurisdiction, whether you're partially implementing things, whether there are warning signs that people should be thinking of when they're implementing tools, anything like that. So just let me know. But we usually recommend folks start with the Select Focus Areas worksheet that just really goes through a high-level overview of the CIFOR guidelines and what is recommended, and helps you figure out which of the focus area worksheets you want to use to help with your planning and your gap assessment. So there are, I believe, 9 focus area worksheets, although you don't necessarily want to start with one and work your way all the way through. The first worksheet focus area, number 1, is relationships. And I would say relationships and communication are where I've seen folks start most often when they use the CIFOR Toolkit. I think it makes a lot of sense because relationships, that focus area worksheet, is really about identifying all of the people that should be on your outbreak investigation team. Now, for folks that have done this kind of gap assessment or planning, maybe you don't need to work on focus area 1 with relationships. Maybe you want to skip right to focus area 3, where you talk about communicating with the relationships you've already established, or what kind of protocols you need to have in place before an outbreak starts to help with communication. And focus area 2, necessary resources. This is also a popular one for folks that are just kind of starting the process. And we do see folks, I think, probably gravitate more towards focus area 3 when they're starting, but necessary resources is exactly what it sounds like. It's a chance to be able to take a look at what CIFOR recommends that you have in place and how close you are to getting there. So what does a CIFOR toolkit facilitation look like? Well, typically you're convening stakeholders on your outbreak investigation team. Depending on how you want to do this, it might be really important to consider having a balance of upper management that are decision makers and folks that are working on the line that have the experience to know what the state of affairs actually looks like. So we recommend getting a good mix in there. And typically you want to get these folks together for a day, maybe a half day if you're just doing one focus area worksheet, and plan a meeting to go through the focus areas and assess the current state of affairs. We recommend in the CIFOR guidelines that you would have both a recorder and a facilitator on site. Depending on the size of your group, you may want to have multiple recorders and multiple facilitators, because there's going to be a lot of discussion, hopefully, if things are going well. And it's helpful to have a scribe around that can write down all of the good ideas and feedback that's free-flowing. Facilitators help get that information, that dialogue going. And it's helpful to have someone around to kind of prompt people, maybe folks that aren't giving feedback, try and point to them and say, hey, where do you stand on this position? And I do want to offer that the CoE sites are happy to help with CIFOR Toolkit facilitations. We can be part of that. We've also done kind of an overview of what the CIFOR guidelines are at the start of a toolkit facilitation meeting to kind of set the stage for what the CIFOR guidelines are and how they're meant to be used. But the basic flow here is that you start with the fundamentals. with the toolkits. If you've assessed that you are ready to go in those focus areas, you move on to more advanced planning as you go. All right. So another thing that we point to in Oregon as part of our daily practice, if you will, is questionnaire templates. We have several different templates that we use in Oregon. Many of them are, actually most of them, maybe all of them, are related to a specific data system that is designed to be used specifically with that template. But that doesn't mean that you have to have a specific data system built to use a template. It just means that you need to plan to use a data system with your template before your outbreak gets started. So questionnaire templates are great. They facilitate rapid data collection, rapid data entry. They make cleaning your data easier because you have less surprises with what you're getting back. And they really help for us with rapid analysis. We take consideration when we're developing our templates to determine what's going to be the fastest data entry if we do indeed need to print a questionnaire out. We're starting to pivot, and I think other folks are doing this as well, to live data capture within our systems. We're building that more and more as we go, but sometimes it's helpful to have a situation where you can print out a bunch of questionnaires and have them handed off to a group of interviewers to get going as soon as possible. So it's really important that you spend some time planning this. I like to say that Outbreak questionnaire formatting is an art and a skill for sure, but it's nice to be able to have a template because you won't have to spend time beautifying it before or during your outbreak investigation. You can take time perfecting the formatting beforehand. And what we want to do with our templates is to be able to plug in question text or numbering very easily if we need to. The other option is preferred to have standardized questions that appear on every questionnaire. Typical questions that we know we're going to ask every time, and we don't want to have to go through the bother of typing out the question for every investigation. They'll stay on our questionnaire templates as standard questions. This also allows us for planning about how we can export our data when we're done entering it, and if we need to analyze it in a separate statistical package, what kind of formatting we need to have in place when we're capturing questions in one system and bringing the data into another. So here's a shot of our standard questionnaire template designed by the late, great Dr. Bill Keene about 15 years ago. This is a great example of a questionnaire that has had a lot of time put into formatting. So what you're looking at here, what's not shown, I should say, are a page or two of very detailed instructions on how one can use this template with or without the related data system. But what you're seeing here is the first page of the questionnaire. So everything that appears in red, like the Bill's Burger joint name of the outbreak at the top, everything that appears in red should either be modified or you should consider whether or not you want to keep it. We may not need to capture state, for example, for an outbreak investigation that's happening in a local restaurant chain. So those things appear in red. And this is the questionnaire template we're typically using for event or venue-centric outbreak investigations. So where we have kind of a limited universe of questions we're going to ask about, and then we're going to want to ask some standard questions about symptoms and onset. The black text on this questionnaire should not be changed, and the blue text that appears on here should be instructions for the questionnaire designer. But what you can see here is that all of this is appearing in a Word document, which means we can go in and type on any of these lines pretty easily. We can change the numbers pretty easily. They're typically represented by X's. At the bottom of the template, there are typed out numbers and rows that you can paste into columns. The checkbox set does not get modified, but the text next to it is in a separate set of tables, and those get modified for each line. You can add in other things that you need. You can take away what you don't need, and it comes with calendars as well. This is the last page of the questionnaire, always the last page. in the previous set of questions, the last question before you get to this page is, did you have any symptoms? That way, if you're interviewing someone that had the exposure with the cohort but didn't get sick, their interview is over. But if they did have symptoms, the interviewer is instructed to proceed to the next page. So this is kind of our standard set of what we've decided we want to ask about for typical gastroenteritis outbreaks. We're always asking about the same set of signs and symptoms, and we're always asking the same kind of structure for onset and duration. We specifically ask about 2 different types of onset dates. We ask when they first started feeling sick and the time, and then we ask when they first started having vomiting or diarrhea. This helps us to pinpoint on what we call the hard symptom rather than the soft prodrome, and may allow us to focus our epi curve a bit more, especially if we're dealing with folks that have had multiple exposures together. This might help us pinpoint a more specific time or meal where folks were likely ill. And then we have some standard questions about other folks in the household that were sick before they were. Did they give a stool specimen? Have they received medical care? But this questionnaire, the only thing that changes on this last page with symptoms are the dates. So it's highly standardized, and it makes it really easy for us when we're doing an investigation to just plug this in and go. We've spun off these templates also in Oregon because we use them so often. We've made a couple that are outbreak specific. So we've got a raw milk outbreak questionnaire template. This was developed by looking at raw milk outbreak questionnaires in Pennsylvania, California, Minnesota, and Oregon. And we kind of came up with a list of the usual suspect of questions that we'd want to ask during a raw milk investigation. So this is the instruction page. That is at the beginning of all of our questionnaire templates. And here's a shot of kind of what the template is itself. This one doesn't have the different colors for what to remove or what are instructions, but rather just a whole bunch of different questions grouped together, questions for the household, questions about milk delivery, questions about herd shares, question about other folks, other milk sources, just a lot of different questions about milk. So anytime we have a raw milk outbreak in Oregon, we're starting with this questionnaire. So as I mentioned previously, plan for analysis. It's great to have a standardized questionnaire template or a standardized questionnaire in mind. We'll talk about HGQs in a minute. But the questions you're asking yourself when you're designing your questionnaire should always be, where will this questionnaire data be entered? Where will the data ultimately be analyzed? Do I need to prepare an export to create a report? Do I need to export to create graphics or charts? Like I said, for us, our questionnaire template system is compatible with data entry on our homegrown system, which is designed in FileMaker Pro. But we're also have built one in EpiInfo. We're tweaking it a little bit. So we've basically taken the existing template questionnaire that I've shown you and built a data entry system in EpiInfo. And we are working to use the EpiInfo web survey so that we can deploy this online to folks as needed. But we're doing this planning ahead of time because we know that when we're in the middle of the investigation, it's hard enough just to get it all together and get your questionnaire design and find your interviewers and go. So we've seen this work in the past. I believe there's a write-up from 2006 about a frozen oyster outbreak, a norovirus outbreak that was a model for this template system, and they were able to identify the outbreak and identify the vehicle, I believe, within 48 hours of the first time they measured it. So we really think about how can we save time during the outbreak investigation before we detect the outbreak. And these questionnaire templates are available through the CoE Tools website and the Oregon CoE site as well. Another thing to set yourself up for success is to determine if you want to subscribe to a phone number search service. I would say we've had varying success with things like whitepages.com and trying to get to them to see if they have the ability to get cell phone numbers with a subscription. Spoiler, they don't. But there are some pay directories that contain things like cell phone numbers or additional information that you're not going to get for free on the web. When you're doing active case finding in a situation like an event or a venue-centric outbreak, you may be able to get a list of credit card receipts from the proprietor, but then you're stuck trying to find a way to contact these folks. In the age of cell phone portability, as far as numbers from state to state, it's sometimes difficult to assume that you'll be able to find them by the location alone. So it's a good idea to consider whether you want to pay for a service that will allow you to do a deeper, more granular search. Oregon, I can tell you we're using right now is called Accurant. It's a service run by LexisNexis. It is a lot of information that you can access. There are legal requirements that you must demonstrate as a government entity, which takes a little time but is relatively painless. But you have to have a reason to be able to look at this information that's available through Accurant. And one of those reasons is public health and disease surveillance in particular. So while you will get landline numbers, you also will get cell phone numbers, and they're a little bit better about identifying how long the number's been in use, whether it's disconnected, whether there are multiple numbers. Sometimes you'll find folks that own property in multiple states, so they'll have multiple numbers that you can try. It is a nice service. They do have very, very strict terms of use, I should point out. And it is slightly expensive, but I think so far we're pretty happy with it compared to what we were doing before. And the accounts, I should mention, are single user. Every time you log in, they're going to make you click 3 things that says, I swear to God, I'm not going to do anything you don't like, and I'm going to mind my own business. So that's something to consider, a phone number search service. I don't know if anyone else has had any success with other phone number search services or subscriptions that they want to mention, but I'll pause for a moment to see if anyone has any ideas they want to throw out about this. Okay, well, feel free to interrupt me at any time if you have something you want to share. Another thing that you can do either before your outbreak investigation or right as you're about to start your investigation is work to train your interviewers as soon as possible. The COEs do have a couple rapid interviewer training videos available. I believe that Colorado has some detailed information about onboarding new interviewers. And I'm going to talk a bit more about the Oregon side, but I did want to mention that Colorado has interviewer training resources. Minnesota has some interviewer training resources about setting up a student team. So there's a wealth of information coming out. But for us in Oregon, when we want to quickly onboard new interviewers, we're typically having them review this video with us. So we have 3 different versions of this interviewer training video. There's a 4-minute version, a 10-minute version, and a 30-minute version. The 10-minute version just reviews what we call the 10 cardinal rules of effective interviewing with some discussion, some brief discussion. The 30-minute video does more to explain the outbreak, the background of outbreak investigation. There's a brief tour of the Outbreak Museum. There are 2 sample interviews that are exercises, and there's a handout that goes with them for your trainees with a separate answer key. And there's a companion slide deck that's available for customization for an in-person training. And then the 4-minute video is just the sample interviews if you just had some need for somebody to look at those as exercises separate from the rest of it. That is a spin-off as well. So, you know, the cardinal rules rather go through kind of our best practices. This is number 4, avoid leading the witness. You know, don't ask leading questions. Don't say, well, you wouldn't have done that, would you? Things like that. As part of the video, the interviewer actually has a bit of an argument with the narrative about what constitutes avoiding leading a witness. But I'll let you check that out for yourself if you're interested. And before, I think this is the last one in our pre-outbreak section, but you need to plan to collect some poop, right? The CIFOR guidelines make it clear that it's not just our laboratory and friends, not just their responsibility to make sure that we can get specimens. They test them for us, and that's amazing. But epidemiologists need to be familiar with how to get specimens from cases. So what we recommend in Oregon and have done ourselves is to design a comprehensive specimen kit. A specimen collection kit, excuse me. That's going to be something where you can come up with a standardized list of equipment to send out to cases and give them some non-scientific instructions to go along with it. You also can use this opportunity to create specific instructions for public health staff, maybe if you're in a decentralized state, for example, and working with local health departments to get those specimens in hand. It also gives you the opportunity to plan for drop-off and pickup. Maybe, do you have a courier service locally? Do you need to plan for mailer tubes to send the kits out and to get the kits to the lab with full specimens? So in Oregon, we have this is what we call our IT kit. It comes with customized instructions. I'll give you a peek at those next. A toilet liner, a paper bowl in case things get watery, a mini lab slip. We had been giving out the longer lab slip with the specimens in the past, and it probably had 70 fields, and they only needed to complete 3 of them, and it overwhelmed a lot of our cases. So we just made a mini lab slip that they can send in with the specimen, and then the lab has the minimum 2 identifiers that they need to run the specimen, and we have information about when the specimen was collected and when their onset was if we don't already have that. We always include, of course, a specimen bag with absorbent material as recommended by our lab, gloves, a spoon to help them move things around, a paper sack in case they don't want to look at their specimen after they've collected it, a specimen cup, and, sorry, I'm blocked by this webinar thing, an alcohol pad, there we go, and a gauze pad. So those are the components of our IT kit, our specimen collection kit. So this is what our instruction sheet looks like. We're working on revising this. We've gotten some feedback that it's a little bit wordy, and I get that. Our most recent version, in that blank white spot, has a QR code to go to our video that I'm going to show you a couple screen grabs of. As you can see in the bottom right-hand corner, we've left a spot for the local health department to communicate with the case about what to do with the specimen when they're done with it, and the phone number perhaps. You can print out labels and just stick them on. But our instructions give them an idea what's in the kit, how do you use the kit to get a specimen. If you're desperate, try to grab the specimen from a diaper. We don't really like that, but you can if you have to. And then how to pack it up and how to get it back to us. We print this double-sided in English and in Spanish as well, just in case. And at the bottom there, you can see we've got the toilet with just a liner and the toilet with the bowl put into the liner. So yes, they literally can pour it out of the bowl into the specimen cup if that's what they need to do. So how does this work for citizens real quick? They tape it to the toilet seat, they put the liner in, they go in the liner, they transfer the stool to the container, they wipe down and label the container with the alcohol swab, they fill out our mini lab slip, and they return the specimen to the health department. We've typically left it up to the locals to determine if they're going to go out and pick up specimens or they're going to be requested to drop them off at the local health department, where our courier service will pick them up. Depending on the schedule, some folks get everyday pickup from the courier. Other folks have fewer services but can order service on demand as needed. It's that easy. We make these IT kits available to local health departments for free. They can order them through our state lab, and they can also request additional Carrie Blair to go along with the kits, which we recommend they keep Carrie Blair on hand separately in case they're in a situation where we want them to aliquot a specimen. How it works for health department staff, well, they customize the instructions like I mentioned. They give the kit to the victim. They arrange for pickup. They use that small lab form to fill out our large lab form here before they turn it into the lab. They aliquot to Carrie Blair if they need to. They label the specimen appropriately if it hasn't already been. Attach the barcode from our lab sheet. Check for leakage, of course, and then they send the specimen to the public health lab. Here's a couple shots of our video for our victims that are going to be giving us stool specimens. We do a pretty clear shot of the different items in the kit in case they don't feel like reading the instructions. I feel like there are a lot of people that aren't that interested in reading a page of instructions on how to deal with their poop, so we made a 4-minute video. But here's a shot how to get the collection there. For anybody wondering, that is dyed cottage cheese. Didn't get quite as blue as I thought it was going to. And that's our fearless web guy, Jeremy, who produced this video for us as well, getting the specimen out of there. Here's the lab slip. We tell them, look, we don't care about a whole lot of stuff, but we really care about this. We really need this information from you. And they fill it out and they include it. So that's kind of a snapshot of the things that we've done in Oregon to prepare ourselves for outbreak investigation. I would say, you know, anybody that's interested, we have a price breakdown of the IT kit. It costs about, I think last time, like $2.85 per kit without Carrie Blair. And a couple of our regional partners have adopted a version of the IT kit, so we're pretty proud of that. I think there's a similar version now in Utah and Idaho. I don't know if anybody is on that wants to talk about that. Colorado and Minnesota and Tennessee all have separate specimen collection kits and related videos that you can sample. Take a look and see. Maybe one of these will inspire you if you're looking to improve your kit. I'm going to pause for a moment and just leave some space in case anyone is interested in talking about any of the things that they're using in the framework of preparing for outbreak investigations as far as model practices.
Hi, Hillary. It's Alice in Colorado. So I just wanted to highlight the Oregon videos. So in Colorado, we are not able to have like a permanent student team or a student team in place, but we do have some MPH students that we call on for surge capacity, but really we only utilize them a handful of times per year. So we use the Oregon videos as a refresher to a longer training we give twice a year. So if students are coming in to help us do some interviews, we show them that video as sort of like a refresher and part of the really brief training we give them before they start doing interviews on a specific investigation. So we really like that video a lot. And then I will just add that Christian N in the chat box added the website truepeoplesearch.com, which I think is related to the obtaining phone numbers. I'm not particularly familiar with that one.
Nice, nice. So it's Kristen, did you want to say anything about that? I'm happy to give the floor here, but you may just wanted to have chatted about it.
Sure. Can you guys hear me?
Yes.
Okay, perfect. Yeah, so we also use, so I'm from the Southern Nevada Health District, so Las Vegas and the areas here in Nevada. So we do use also LexisNexis as well, but sometimes you know, we also go through other avenues as well, such as truepeoplesearch.com. I found that that could be quite useful, and sometimes I have been able to track people down through there as well. It gives you a list of, you know, potential current address as well as previous addresses. I believe it gives you the dates, and it gives you current phone number and past phone numbers. So we found it pretty useful. You could search by address, by name, by phone number as well. So we think it's very useful.
Nice. Nice. Thanks, Kristen. Anyone else have any comments about the phone number search services or anything else they're using? Like, okay. Well, feel free to use the chat box. Thanks for keeping an eye on that, Alice. And again, please interrupt me if you have some comments or questions about things that I'm presenting here, or if you want to talk about how you've used these same tools. So outbreak investigation. So as expected, when we talk about questionnaire templates, we want to include something for hypothesis generation. Depending on the different sites, I surveyed the states a few years ago to try and get more information about what folks had been using, and I neglected to include those numbers in this presentation, but most folks were using a default hypothesis generating questionnaire that looked like the National Hypothesis Generation Questionnaire. So that, probably most folks know this, but CDC has just recently updated to version 2 of the NHGQ, and I think it looks pretty good. There's some new categories, some different approaches, and some revision of some of your favorites on there. But by and large, folks are either just using the NHGQ for either their own local cluster investigations or when they're participating in a multi-state investigation. And then a bunch of folks have modified the NHGQ and added some local questions or some additional questions they wanted to have covered. So the NHGQ is available as a template, most folks probably know, but through EpiInfo. And that gives you the opportunity to be able to modify it if that's what you want to do. Additional HGQs that are on the market are the Minnesota Long Form Questionnaire, the classic HGQ standard interview that Minnesota does with their enteric cases, and the Oregon Shotgun Questionnaire. I would say the Minnesota Long Form Questionnaire is a bit more open-ended in spots, includes things like multiple day food history, while the Oregon Shotgun Questionnaire is almost exclusively quantitative, closed-ended questions with a few exceptions. So, typically folks are having these questionnaires available. The idea is to make sure the EPIs on your squad are familiar with HGQs and, which ones have which questions that you might want to cover. Some folks are just, like I said, pivoting to the NHGQ during multi-state investigations. That's what we do here in Oregon for our Salmonella and our STEC cases that are eligible for sporadic case shotgun interview. We're using our standard questionnaire here. And then if the case becomes part of a multi-state cluster investigation, we'll either transcribe from our shotgun interview or we'll pivot to the NHGQ as needed for a multi-state investigation. As with the other questionnaire templates I discussed, it's important to have a plan for analysis. In Oregon, we built a specific system that will allow us to customize the questionnaire, to focus the questionnaire down as we get more cases interviewed in our cluster, to do data entry, to do analysis, and then it's also where we're aggregating case background info. We always advocate, I should mention, for version control as well. I also wanted to mention for those newer epidemiologists working on investigations, or maybe folks that haven't done this in a while, there's a great refresher video that's available from the Colorado CoE on how to create an Excel EpiCurve. It walks you through the whole process, and it's nice and clean, and as you can see there, it's about 5.5 minutes. So if you're struggling to remember how to do that, this is a great resource to check out. Binomial probability calculations are something that we recommend for cluster investigations here in Oregon. The idea is that you do the binomial calculations, and if you have significant foods, you can work to do traceback and help get to a rapid food identification in your outbreak. We've seen the hypothesis generating questionnaires becoming standardized at a national level, so that makes it easier to compare background rates of different foods. And if you didn't know, the CDC EpiInfo app features a binomial calculator that you can use on the go. Here's the formula that we're talking about for binomial probability calculations. The question we're asking is, by chance alone, how likely are we to find X of N people or more eating a given product? It's a probability score, so it is kind of like a heads or tails situation. As you can see there, our formula requires that we have a background consumption rate that we can plug in to do this kind of calculation. Sources of background rate estimates. The tried and true is the FoodNet Population Survey Atlas of Exposures. There is a new wave of this survey in process. If you hadn't heard, hopefully data will be available. I'm feeling like 2019 might be the year. Depending on your investigation, you could get restaurant sales records and potentially get background rates for your venue-centric kind of investigation. You can also use aggregated case surveillance data. We're working together with the COEs in 15 states right now to aggregate case surveillance data from our Salmonella and our STEC cases to use as background rate estimates. We're calling this Project Mercury. Mercury is HG on the periodic table, so we typically refer to this as Project HG. The idea is that all of us have different databases and we want to work to liberate our data. Oregon and Minnesota have been starting this process. Minnesota's is published, Oregon's is not, but they can both be queried depending on your need. But the idea is that we're going through and comparing everyone's questionnaires and coming up with rates that we can compare, calling this Project Mercury. And then it's aggregated and hopefully in the very near future going to be searchable. We have data in from 4 of our sites now, and I hope to be publishing this within the next few months. But if you don't have it available for you on the web, you can always query us in Oregon, and we're happy to share what we have for your outbreak investigation. So right now, these are our Project Mercury sites that we're working to get data from. And it's been an ongoing process that we're excited to collaborate on. If anyone's interested in hearing more about this, please contact me. We can work with you to get into this project at pretty much any place you are on the spectrum of disease surveillance for Salmonella and STEC. But here's a shot of Minnesota's report. It is fantastic. This is the dairy section here. But what you're looking at, you've got your food item, your food item in the left-hand column, how many people were asked about that item, the percent who said yes, in this case, for the first row, eggs, 65% said they had eggs. If you include the maybes, it was 70% said they had eggs in the 7 days before illness. And then that breaks down 65% of females and males, kind of even across the board. You see age breaks down from 61 to 67%, depending. And seasonality doesn't seem to be too crazy, but there is a bit of a difference. Looks like it drops off in the fall and picks up again in the winter for peak egg consumption. And then Minnesota's also included the POP survey information that was collected for that variable. So for the POP survey that was done, 77% of the folks interviewed said they had eaten eggs in the previous 7 days in Minnesota, and 75% overall for the POP survey national number. So Minnesota has put this out for pretty much all of the items on their questionnaire that make sense to aggregate. Oregon is working on developing this. This is a shot of our report. We've got 750 exposures right now that we think are appropriate to aggregate for our Salmonella and STEC cases. And we've been capturing these data prospectively since 2013. So we'll have a 4 to 5 year data set coming out when we publish. But we've pretty much copied the style of Minnesota's report here. And if you need this information, again, please query us. We'd love to share this with you if it's helpful to give context to your investigations. Just a brief example of how the binomial has been used. The Listeriosis outbreak with caramel apples. When we heard about this in Oregon, it was 28 cases in 10 states. Sorry, that should be 26 of 28 hospitalized, 5 deaths. An interviewer had already generated a caramel apple hypothesis with doing the regular Listeria interviews, but they wanted to know if they could do a binomial calculation instead of pivoting to a case control study that may take multiple days, and that was not something that was an attractive option with that many deaths and hospitalizations among cases. So they queried Minnesota and Oregon for background rates about our questions about apples. We shared that the range with our data was 47 to 53% saying yes to apples out of the 734 people we had asked from cases of Salmonella and STEC. And we provide some additional detail from 249 cases that gave us information about the type of apple that they ate. CDC was able to use the multiple background rates of apples and come up with a rather conservative estimate. At this point, when they were plugging in the binomial model, there were 35 people infected, and they had interviewed 31 people. 28 out of 31 people, you'll see at the bottom there, are 90% reported eating commercially produced prepackaged caramel apples before becoming ill. Now, since none of us were asking about caramel apples, who even knew that was a vehicle to consider for listeriosis before this outbreak? I sure didn't. But they were able to use these figures and plug it into the binomial calculator and figure out if this is something that would be statistically significant and whether they should proceed with Traceback. So here's a shot of the binomial calculator developed by Dr. Keene. This is on the Oregon CoE website and the All CoE website. But it's the same basic premise as the CDC EpiInfo calculator on the go and the EpiInfo app. You plug in your sample size, so 31 cases interviewed. We went with a CDC went with a 60% background rate, but we also did when we did this calculation. We thought that was a very conservative estimate, considering that this was the higher average of apple consumption across the country, and we're talking about caramel apples here, not regular apples. So this background rate is likely to bias away from the null. So here we have what it looks like when 28 people, or 90%, say yes. The cumulative probability is 0.0002. So we feel pretty good about that, and they were able to proceed with Traceback and getting these off the market very rapidly. Salmonella, my apologies, I meant to take this slide out. Salmonella and raw sprouted nut butter had happened recently in 2016 was the end of this investigation. Around the same time we were building up our Project Mercury data. We had 6 cases of Salmonella paratyphi B tartrate positive Salmonella. There were 100% that reported eating any nut butters when we interviewed with a focus questionnaire. Looking at the background rate of peanut butter, which was the only available comparison in the FoodNet POP survey, the binomial of 100% eating nut butter versus 58% eating peanut butter, the p-value was still 0.04. But we wanted some more context. Oregon had a question on their questionnaire about ground nut butters, pastes, and spreads from Oregon background rates. We devised that it was 9.2% of cases that had reported eating this in the week before illness. When we plugged in 100% 100% consumption of other nut butter versus 10% background rate, there were a lot of zeros in front of our p-value. 38% of our cases had eaten peanut butter as well, a little bit lower than the FoodNet POP survey. But only the question of other nut butters, that was only captured with Project HG, Project Mercury information. A couple other things I wanted to touch on for during the investigation piece. Minnesota has developed some great key points series. We have definitely been referring our newer EPIs to this as they need to learn about Traceback, and I'm sorry, I'm on the wrong one here. This is obtaining food transaction records from credit debit cards. They have a key point series about both of these things. But in this one, this is helpful if you want to be able to obtain more information about the location and date of purchase. If you want to supplement the food history that's collected on your questionnaire, it also helps to figure out if you need to get information about whether purchase locations are in common. The way it works typically is the case either reprints the receipts, possibly at the point of sale, or the public health agency works with the vendor to get digital receipts. Written consent may be required. But if you've been wondering how you might be able to get these kinds of food transactions from these cards, the Key Points series is a great tool to go over the finer points of what you want to consider. Colorado has developed a food source wiki. This is a great resource if you are a bit ignorant about a food that you're considering as a vehicle in your outbreak investigation. It's designed to help educate EPIs and medical staff about basic food facts, food production practices, post-harvest, pre-harvest, food distribution systems, and they're updating right now on associated past outbreak vehicles, past outbreaks with these specific food vehicles. It's really helpful to look at this page to understand the biologic plausibility of contamination. We like to send our new folks to the sprouts page that's on here in particular. Some people are just not aware of the risk of sprouts, and it becomes elucidated when they read how they're produced. It's a really good resource if you want to learn more about a vegetable or a produce item in particular. They have other food items such as oysters. It's a good resource if you just need more information about how this food is manufactured and how it ended up making somebody sick potentially. Here's the Key Points series I was talking about with Minnesota, product tracing. So they have a two-part Key Points document on this, which is great. They have written together with CDC a white paper about Traceback investigation that's quite a bit longer, but the key points are really just that, the things you need to know to make this happen right now. It goes over situations where you might want to use it. So you should be considering Traceback if you have cases that are in multiple jurisdictions or states, or when your case interviews just don't reveal a common exposure, or your case interviews suggest a commercially distributed food product. These are all situations where you might need to be doing Traceback. If you've implicated a suspected vehicle but you don't feel like your evidence is quite strong enough, this is also another great time to consider Traceback. And the key points document goes over these. But then it also highlights the places where you definitely want to trace back. For example, if you're doing a subcluster investigation associated with multiple restaurants or institutions, you need to be tracing back. Food is, if it's statistically implicated, but there's concerns about foods that are consumed together. Maybe you're concerned about confounding or stealth foods that might be in the mix that aren't picked up. Start tracing back. If you've implicated more than one food in your binomial calculation, start tracing back. And then, if you've got a borderline statistical association with a food, I'd also consider tracing back as well, especially if you have no other hypothesis or if you have multiple competing hypotheses. I'm not going to go into this too much because it's running out of time, but you can check out the document there for what to gather when you're doing traceback. Here's a shot. The second key point is really talking more about conducting the trace. So the first key points document, when do I want to do a traceback? Why do I want to do a traceback? Part 2, how do I do a traceback? We definitely use these resources here in Oregon. And here's the title of the white paper I mentioned, Product Tracing and Epi Investigations of Outbreaks Due to Commercially Distributed Food Items, Utility, Application, and Consideration. This was published in October 2015, this white paper, and it has a lot more detail than the key points document, but may not be something you have time to read during the investigation, as we frequently do not. So post-investigation, wrapping this up here, what do you want to consider? Well, we're pushing pretty hard the after-action report here in Oregon. We don't do this as often as we used to, and I hope that we get a chance to do a bit more often in the coming year as more tools are available. But the after-action report is sometimes called a hotwash. It's a no-fault process, right, where you can come together with all of your team members. You really do need to have someone representing all the groups on your team to evaluate your outbreak response. You want to emphasize identifying your strengths and weaknesses of your plans, of any protocols you have in place, of any procedures that you use, tactics that you use. Just really consider, did this work? Should we repeat this? Or what do we need to change? You can create an improvement plan. Ours is usually a pretty informal process in Oregon until it becomes an SOP. But the FDA RRT Best Practices Manual that I'm going to recommend here, it also has a very formal way to approach an after-action report. We also take the after-action meeting as a great opportunity to review contributing factors. Depending on your state and whether you're reporting to NERS, there may be different contributing factors that are being captured by environmental health and epidemiology, and this is a great time to come together with your full team and discuss what contributing factors make the most sense to report. As mentioned, the FDA RRT manual, it has a lot of detail about after-action reports. It outlines suggested roles. It gives example reports. It has a report template. We've been starting to pilfer this a bit, and as I understand, CIFOR is considering developing a less detailed after-action report tool as part of their repertoire. The Colorado CoE also has a section on their website about tools and tips for conducting a hotwash with planning suggestions and rationale and templates. And oops, there I've repeated the RRT part again. But there's two really good resources out there. Like I mentioned, the FDA report manual is long, but the after-action report part starts on page 478, if you're looking at that now. This is kind of the full scope here, and you'll see down at the bottom attachment D, after-action report template. Also, a suggestion to write up your report. Now, we all know about publishing in journals, and that's just wonderful. But you could also submit your investigation to the International Outbreak Museum, and we'll share it on outbreakmuseum.com. What we're looking for is a written narrative. I'm talking, you know, background, methods, results, and discussion. Doesn't have to be super detailed manuscripts. We're typically looking for 8 to 10 basic data points that we put in a table at the start of your web page for your outbreak. And we love it when folks can provide pictures, copies of questionnaires, diagrams, charts to go along with their write-ups that we can share on the website. And as a bonus, displayed by one Tasha Poissant, Epi Extraordinaire here in Oregon, we'll give you a free Outbreak Museum shirt if you would like to submit your outbreak for the website. And if you want to work as a team, we'll give everybody on your team a t-shirt. So feel free to contact me for more information about that. And that is all. So I'm going to pause here and see if anybody has anything else to share.
Hey, Hillary, this is Tamara in Tennessee. I did want to add that we actually have created a red cap version of the NHGQ as well, and so that is available for those who prefer to use red cap or are moving in that direction, and that's available on the Tennessee COE's website or through the All COE Products website.
Nice.
Hey Hillary, this is Ingrid in Colorado, and I just wanted to throw out too that I believe all of the COEs will do facilitation for any Hotwash or after outbreak recap that you all want to do. So definitely use that because we are a great impartial resource.
Excellent point, Ingrid. Yeah, it is nice to get a third party sometime to facilitate that. Absolutely. Anybody else? Any questions or other comments?
Hillary, this is Alice in Colorado. I just wanted to add a localized example of using the binomial. Here in Colorado, Tri-County Health Department investigated an outbreak associated with an Italian restaurant. And they had a limited number of controls after they tried doing a case control study. So they ended up using the restaurant data they had and the binomial probability worksheet to calculate the background. They used the background rate with consumption of pizzas at the restaurant. This is just an example of the food. So the number of pizzas sold over the total number of restaurant guests. So I think that's a really cool example of using the binomial for a more local outbreak.
That's very cool. So yeah, they got some sales data from the restaurant and were able to use that to estimate background. Is that what I'm hearing?
Yep, exactly.
Very cool. Thanks, Al. Well, looks like we're about 1 minute out here, so unless there's anything burning or maybe I've missed something in the chat box, I'm not looking at it right now, I will call it good here. Feel free to hit me up if you are interested in more information about anything I've presented about. Thanks very much.
Thanks, Hillary. So I just wanted to remind everybody that the recording for this webinar and the previous 4 recordings are available on our website. And I have had a direct request, Hillary, for your slides, if you're willing to share them. We can circulate those or add them to the website as well. All right. Thanks, everyone.